Okay, I think we can start.
Okay, sounds good. So thank you for letting me do this. I'm very excited to talk about this case.
Of course.
Okay, so I think I probably know everyone, but I'm Corinna, one of the PGY3s. So I'm going to tell you today about a case of an 86-year-old lady with a past medical history of asthma, Crohn's disease, a recently diagnosed DVT, started on Xarelto, who came into the emergency department with an 8-day history of progressive rash. So the history of the presenting illness. So she received the Moderna booster vaccine 8 days prior to her presentation. The following day, she developed erythema at the injection site. Then 2 days after that, on day 3, she came into the ED for the first time with a rash and right lower extremity swelling. The rash had progressed from being just on her arm to these discrete scattered macules that she had on the trunk and extremities. For the right lower extremity swelling, she was diagnosed with a DVT and started on Xarelto. And then for the rash, she was started on prednisone 40 milligrams daily and asked to follow with her dermatologist. On day 6, she emailed her dermatologist photos of her rash. Her dermatologist was concerned there was a vasculitic reaction to the Moderna booster. So she increased the prednisone dose to 40 milligrams daily. She also prescribed topical triamcinolone ointment, and she recommended the patient go to the emergency department to have blood tests done. In the ED, she described the rashes covering most of her body. And when asked, she reported her only new medications were Xarelto and prednisone. So I would like to stop here and ask people what else they would like to know at this point.
Any fevers?
Yes, she did have a fever, not in the emergency department, but she had recorded a fever 3 days prior, which was 100.4.
Any involvement in the of the mucosal membranes?
No.
Did she have any history of rash or any derm diseases before?
No.
Any like joint diseases or anything like that?
No. And then if people want to share what they're thinking about as well when asking the questions, if they're like specific trains of thought, diagnoses you want to rule out, or feel free to share that too.
I just want to ask if she had any history of blisters in the past or this time.
She said no.
And there's a question by Frida, actually 2 questions. Where was the vaccine given? And the second question, any reaction with prior doses of the vaccine?
What do you mean by where it was given? Like where on the body?
Yes.
It was given, it was on her left arm. And no prior reaction, no reaction to prior doses.
Did she have COVID before?
No. Not that she knew of anyway.
Did she notice any lymphadenopathy?
I didn't ask her about that specifically, so I guess I can't say yes or no.
Any travel? I mean, I guess kind of unlikely, but did she do any hiking or something?
No, no recent travel. She had been isolating. This was in the late fall, so still very much in the thick of things.
Any breathing issues?
No.
And there's some more questions in the chat. Fatma is asking, what about her Crohn's? Is she taking immunosuppressive medications?
So for her Crohn's, she takes mesalamine.
Okay, and then is the rash itchy?
The rash is itchy, and it's also painful.
Okay, and then any prior history of DVTs?
Yeah, she had a DVT about 16 years prior, was on anticoagulation for it for some amount of months that she couldn't recall and then stopped.
And then Abhinav is asking, any neurological or urinary symptoms?
No. I'm curious why that question.
Abhinav, what are you thinking? What are you trying to rule out? He's asking any allergies to food, meds, etc.
No allergies to medications that she's aware of, no food sensitivities.
Did it get better with the pred?
It did not get better with the pred. It was progressing.
Sorry, I think I was muted, but I think I was asking neurologic and urinary because classic vasculitic involvement. IgA, especially urinary and.
And he's asking any joint pain or swelling, and she's thinking of serum-like sickness.
No joint swelling, no joint pain. She just had the isolated swelling in her right leg where she had the DVT.
Any history of oral contraceptive use and whether the prior DVT was provoked or not.
So I don't know. She didn't know about the history of the DVT, about the workup that was done at the time. She didn't have a known history of any malignancies. So I'm not sure. And it wasn't, it was remote enough that if it was in our hospital system, it wasn't really in like accessible notes. But most of her care was at an outside hospital.
I'm sorry, can I ask you a question real quick? When was the DPT in timeline compared to the Moderna booster?
So the Moderna booster, if we call that day 0, then day 3, she went into the ED and she had right lower extremity swelling and was diagnosed with a DVT.
Okay.
So I see Fatma's question. No, the steroids did not help with the rash. It had been progressing throughout the course.
Are you satisfied with the questions that they asked?
Oh, yes. So I'll move on now. It seems like you've covered most of the things that I would think are important to ask about. One way to screen for like mucosal involvement would be to ask about odinophagia, which I asked about and she didn't have, and PO intake hadn't changed at all either. So just to clarify the timeline, because kind of a lot went on with her, like day 0 was the booster. Day 1, she started having erythema at the injection site on the left arm. Day 3 was her first ED visit. She had the DVT diagnosis. At that time, there were photos in Epic of the rash that she had, which were small, scattered, discrete macules on the trunk and extremities. And then at that visit, she was started on Xarelto and prednisone 40. On day 6, she had a fever of 100.4. She emailed her dermatologist photos that were not in Epic that indicated rash progression. So her prednisone was increased to 60 daily. She was given topical triamcinolone 0.1% to use BID and then recommended to go to the emergency department to rule out renal involvement. And then 2 days after that, she came into the emergency department. We also uncovered in reviewing her chart that despite what she had said about her new medication, she actually had been started on terbinafine 11 days prior to the Moderna vaccination for onychomycosis.
And I just wanted to add before we move on that you guys already asked most of the very important questions. And as Corinna was saying, and also Nora was asking, it's very important to look at mucosal involvement, especially when you have a rash that is getting worse, because you want to make sure and see if it's like a systemic kind of reaction and what sites are involved. And I don't know how often we do that. I don't know actually how often we see like a lot of rashes in the ED that are so, kind of extensive. I think most of the times this is seen by derm, but in general, you need to go over like a review system of all the possible mucosal involvement, which that doesn't only mean to look at the mouth, but really ask them, for example, if they have pain when they urinate, for example, because that may be a symptom of urethritis, or sometimes if let's say it's a very, very bad rash that's involving also the mucosa of the GI system, they might have blood in the stool. So it's very important to look at all of these other things that I don't think we connect very often with a skin rash, but it's actually very important to go over systemic involvement, as Corinna was saying, kind of sore throat, pharyngitis, and I was reading that usually, diarrhea and nausea and vomiting are not associated with systemic rashes, but you might have that feeling of an unsettled stomach, which might actually be a suggestion that there is GI involvement, so that the rash is actually a part of a bigger, process. So these are all things that you guys asked and that we always technically will have to rule out and look at when a patient comes with a big rash like this patient.
Thank you. Okay, so her longitudinal history, nothing too revealing apart from what I already told you. She has asthma, Crohn's, and this is her second DVT. The medications that she's on per her history and then the chart review are the Xarelto, mesalamine, prednisone, terbinafine, and then also the topical triamcinolone. No allergies that we know of, nothing really racy in the social history, and then family history non-contributory for her.
Can I just ask, when was her first DVT?
2006.
So remote.
Remote DVT.
Same leg, not same leg?
I'm not sure.
Okay.
Yeah.
Corinna, sorry, I have one more question. Did she feel like the progression after day 3, like after she was started on the steroids, was faster than between day 0 and day 3 before the steroids?
I'm not sure about that. That's a good question, but I'm not sure about the rate of progression. We do have photos for at least like day 1 to day 3, and then we have photos of day 8. Okay. And you'll see those, and there's most definitely progression at that point. So her longitudinal history, I just went over, and then in her review of systems, the pertinent positives, which she has this widespread rash, she says that's symptomatic, it's painful and itchy. She had the 1 fever at home of 100.4, and then she has the right lower extremity swelling. She wasn't having any further fever or chills. She hadn't noticed any blistering, no pain on swallowing. She didn't have any vision changes or pain in her eyes. She wasn't having any hematuria. And then as far as her initial exam, her vitals were just notable for a little bit of hypertension. And then on exam, she was an elderly, obese lady, looked comfortable and no acute distress, breathing comfortably. And then pertinent findings were that she had, as advertised, lower extremity edema, and then on the right side, and then she did have a skin rash. So that is what her rash looked like. And once you see someone, so initially when I went to see her, she hadn't been ungowned, or she hadn't been placed in a gown, I mean. So she was just in her clothes, and this rash spared her face quite considerably. So there was some suggestion of it when you looked at her neck, but once you started uncovering, like once I got to see her trunk a little bit, it very clearly was a profound rash that required fully undressing the patient to closely look at every inch of her skin, basically. So very key here to have like full exposure of the patient. While she denied blisters, she did have one on her lower abdomen. That was a somewhat flaccid blister. And then that was the site of the injection that had turned into kind of like a hemorrhagic area on her arm. And then her right lower leg had this like palpable purpuric lesion. So any questions so far about exam findings or anything else you want to know about this rash?
Did she have any evidence of bleeding from anywhere?
Like from her skin?
Like gum bleeds or
No,
like anything like that?
her mouth, all the like mucosal skin was intact in her mouth. No bleeding.
And no GI or GU bleeds.
No.
And was she continuing to take the terbinafine during this time?
Yeah, she had been taking the terbinafine.
Corinna, do you know if she lived with anyone that either had the rash before or after her?
She lived alone. And I asked about sick contacts and there were no sick contacts.
And at no point did anyone ever start her on warfarin, correct?
No, she was started on Xarelto.
That's Xarelto, okay.
Mhm. Okay, so does anyone want to give a shot at the problem representation? And I can go back to any of the slides if that's helpful to see any of the information, like of the.
Yeah, maybe we can go back to the history because it's like a long history. Who wants to try it? Otherwise, I'm gonna just pick someone.
Yeah, so 86-year-old lady.
So on, you want to give it a shot?
Sorry, you said I should give it a shot?
I thought I had seen Soran, but I did not. So, and he shouldn't be on this, right? So I'm going to call on Niru.
Sure. So, sorry, I forget her age. Is she middle-aged? She's middle-aged, right?
Elderly, she's 86.
Elderly.
86.
Okay. So this is an elderly female with recent vaccination for the COVID vaccine, Moderna vaccine, presenting with progressively worsening erythema and generalized rash. And also has been recently diagnosed with DVT and found to be taking terbinafine during this time. The rash has not shown much improvement with steroids.
Mm-hmm. So what I put for her, elderly female with, oh, sorry, did someone want to say something?
Sorry, when was the terbinafine? How many days before the vaccination she was started on terbinafine?
11.
Thank you.
Mm-hmm. So elderly female with Crohn's and recurrent DVT on anticoagulation. She comes in with an 8-day history of progressive painful rash and reported fever following the Moderna booster vaccine with recent new medications, including terbinafine, Xarelto, and prednisone. Found to have a diffuse rash on exam, notable for an abdominal blister. And I would add there that one thing you would want to consider in a physical exam for this lady and with her flaccid blister is doing the Nikolsky sign and seeing if it's Nikolsky positive or negative, which I'll go into a little bit later about like the significance of that and what kind of conclusions you can draw from it. So
Can you just explain to everyone what you mean by a flaccid blister?
Sure. So a tense blister is one that is filled with more fluid and I guess is more tense. It's more challenging to rupture or unroof, whereas flaccid blisters just look kind of more deflated and like the overlying skin is a bit more loose. So it's not as it doesn't have as much structural integrity. And often goes with rashes. Flaccid blisters go with rashes that sometimes you just see as having erosions because the blisters have already ruptured. So even if you don't see intact blisters, if it's a rash that causes flaccid blisters, you might see just skin eroded, meaning like disruption of the barrier and like open skin basically.
And I just want to add that Corinna wrote in her problem representation that the rash is painful. And that's important because when you see a rash, if there is other pain or the rash feels like a burn, that's always concerning. So that's a rash that you definitely need to take priority in assessing versus someone that just says it has an itchy rash. So that's an important information to put there in your assessment when you kind of like triaging that patient.
So
Sorry,
what was,
Corinna, there was no palm or sole involvement, right? I think I missed that.
there was not.
Okay.
So what would you
Can
like to do?
Can I ask one more question?
Mhm.
So when you showed her back, it almost looked like you could almost see like the line of where her bra was. So it was more on the exposed parts. Was that similar to how her front looked? So like if you go back one more, you can almost see like maybe like on the left there, like where a bra strap could have been.
Oh, uh-huh.
Was that present on the front too, or was it diffuse on her breasts?
No, so it was diffuse on her breasts.
Okay.
You're thinking like if it was potentially a photosensitive?
Yeah.
Yeah, it was everywhere.
Okay.
Mm-hmm.
And in the winter, there's no reason if this was winter to be
Mhm,
photosensitive, but you always want to look for that because that's sometimes a clue.
Mm-hmm. Okay, so what do people want to do for her?
I want to give IV steroids. For sure.
Like
Okay.
just get on with it quickly.
Okay, Abhinav says biopsy.
I mean, definitely that too, but I just feel like the most important thing acutely would be to increase her dose of steroids probably. I mean, obviously you're going to send labs to make sure there's no infectious source, but I don't know. In someone recently started on terbinafine, I just think most likely this is going to be drug induced. And I don't think Xarelto or the prednisone would cause this kind of rash. And honestly, I've never read of anything in the literature like this with the COVID vaccine too. I think we're like very, I think we tend to anchor on that as being the cause for everything. And you can see injection site reactions quite common, but this is so diffuse that, you know, the terbinafine to me, I don't know if there's anything in the literature about that, but that's not the most common medication to be that people are on. So I would be always skeptical. And yeah, I see Fatma's also mentioning all those labs, which I agree with.
Yeah, so Fatma says germ consult, 100%. Frida says eosinophil count. Fatma also says CBC, CMP, ESR, CRP biopsy, and Abhinav says UA. And then we have ANCA, urine protein, creatinine, UA, cryoglobulins, blood cultures, ESR, CRP, ANA. Okay, so yes, here is what we did for her. ESR normal, CRP elevated, the UA was ordered but not done. The CBC, she had a neutrophil predominant leukocytosis. And there was no, I haven't put the eosinophils in here, but there was no eosinophilia. And then her renal function was normal. And then most of the lab was hemolyzed, notable for an albumin of 2.9. The dermatology consult came to see her quickly enough that, and like the care escalated, that it didn't really become material to repeat these things in the emergency department prior to her transfer. So correct that you would want a derm consult. Blood cultures would not be a bad idea at all, because if there is compromise to the skin barrier, you're more susceptible to getting infections. She appeared non-toxic, and really only the leukocytosis was in favor of any kind of suggestion of infection. She didn't meet SIRS criteria. So blood cultures weren't done, and she was not started on antibiotics. One of the rationales for not empirically starting her on antibiotics would be because if this is like a systemic drug reaction, then you really want to limit medications you're getting and have an approach of take things off rather than put anything beyond treatment of the rash on. So that was the rationale for that.
I would have to say, what would you be treating?
With antibiotics, you mean?
Yeah.
Just like if they're in this patient, I don't think it was necessary, but if you saw like more widespread desquamation in someone else, you might just treat with antibiotics. Yeah,
Yeah, I think I'd be careful of doing that until
Yeah.
you really had an idea of what you were treating. So I think it was good that people didn't add antibiotics for this. So no clear
Mm-hmm. And then we also did not start her on IV steroids because what the biggest concern here would be, well, why don't people tell me? Do people have ideas of what this might be or what you're most worried about?
I guess for like a TEN, I actually can't remember which is which, but for one of them, I don't think it's steroids. I think it's IVIG plasmapheresis. And steroids aren't, I think that they may not be useful. And also if she had the fungal infection with the steroids, maybe there's concern for worsening or like uncovering more lesions.
Yeah, so for TEN, it is correct that there's not a whole lot of evidence to support steroid use. And it is typically IVIG that you go to, and then also anti-TNFs. And I'll talk a little bit more about pathophysiology of TEN later and why that's a good choice. But we held off on IV steroids because we wanted to see the dermatology consult was coming in, and she was stable and well appearing. So I didn't feel like it would make like 2 hours would make a difference. Like it was absolutely urgent to give her IV steroids. I see a question, possibly early bolus pemphigoid and then Nikolsky negative. So it was not Nikolsky negative. There was Nikolsky positive. I didn't clearly say that. I just said that it would be something to check for her, but on exam, she was Nikolsky positive. So meaning if you apply lateral pressure to the blister, it comes apart and the skin desquamates from the area. Yeah, so correct. So less likely early bolus pemphigoid, but I will talk a bit about sensitivity and specificity of the Nikolsky sign as well. Okay, so people, apart from TEN, anything else you're worried about?
Vasculitis.
Mm-hmm. And if anyone wants to share any other differentials, that would be great. Otherwise, if anyone wants to volunteer, if they have an approach to triaging rashes or any system for forming a differential diagnosis.
I guess I have a question. Would you consider erythema multiforme? Because to me, but I'm not, like, they look a little bit like target lesions, but maybe they are not exactly like the erythema multiforme, or that's totally out of the question.
No, so I completely agree. And I definitely think the lesions are targetoid. You can see like they've coalesced a lot on her front, but you can see kind of these like central areas where there's sparing of the erythema, and then it's surrounded by a ring of erythema. And then her back especially, I thought looked more targetoid. And EM for the most part is not blistering, or typically it's not blistering, but you can get like central vesicles in EM occasionally. So that was my biggest thought. I thought this looked very targetoid and thought EM was on the differential. Okay, so hopefully, so now I'm going to talk a bit about rashes in general, and hopefully it's not too introductory of a discussion, but I get the sense from people that generally rashes, like people get intimidated by them and don't have a good system for approaching them. So I'll talk a little bit about how to build a differential for skin disorders. So like anything else in medicine, you need to have a systematic approach to how you evaluate it. And for skin lesions and a rash, the approach starts with describing the morphology of the lesions. So we all need to be comfortable using specific derm terminology to describe them so that we build differentials based on those descriptions. And then at the very least, if you don't have lists of like, oh, this is what causes a papulous squamous rash, and this is what causes a papular eruption and things like that, then at least you'll be far more efficient at looking up on UpToDate or wherever you want, looking up what the possibilities might be. So Do people remember any of the words that are used for morphology of skin lesions? And requisite for using these terms, you have to palpate as well as visually inspect, because the words are dependent on whether lesions are flat or elevated as well.
I remember a macular versus, but like the macular are not raised above the skin, and the lobular was raised, I guess.
Yes, that's a very good one to know. So I'll go over all of the primary skin lesions, so we have the full collection in the next slide. And then the other thing you want to think about is the distribution of the rash. Once you have the morphology, paying attention to how it's distributed is going to help you narrow the differential tremendously, because most skin conditions have like a very clear pattern of distribution, bilateral versus unilateral, widespread versus localized. And then when it's localized, it's not like every single rash can affect the trunk or face or hands. They're specific rashes that you tend to get in these areas. So you can distinguish between widespread and localized. And then with localized, if it's truncal, if it's facial, if it's acrofacial, meaning on the hands and feet and face, if it's on flexor surfaces versus extensors, if it's in intertriginous areas, meaning where skin touches skin, if it's on sun-exposed areas, suggestive of a photosensitive rash. The arrangement pertains to the relationship of lesions between each other. So whether they're scattered, if they're clustered together, if they're linear, if they coalesce, etc. And then once you are comfortable, and then of course you place all of this in the context of the patient, because you're going to get differentials, you know, if you look on UpToDate, that are like for rashes that are far more common in pediatric patients, or like for connective tissue disease, there might be a history of prior connective tissue disease, paying attention to medications that have been added on, making you more highly suspicious of drug reactions. So then once you're comfortable with all the vocabulary and having this systematic approach, you'll also get more familiar with pattern recognition, and then certain descriptions, even if you're just describing in your head what you're seeing, they should trigger associated diagnoses. And we may already have some of that. We probably have already some of that from like step 1 and for med school, that have like very classic patterns, like elevated hyperkeratotic salmon colored plaques with adherent silvery scale. That's usually like a psoriasis trigger, or these papulovesicular rashes on flexor surfaces that are really itchy that trigger atopic dermatitis. But it's also important with what I just said to realize and acknowledge that a lot of these classic descriptions that come up in exams are very much biased toward the appearance of rashes on white skin. And especially in New York with our population, it's particularly prudent to be aware of manifestations of common diseases in skin of color as well, and in skin with darker pigment, because it's not going to be like the classic textbook things that we're used to. So these are the primary skin lesions, and they're unfortunately not clustered in like what's relevant to each one. So the first one on the left is a macule that's flat and sub 1 centimeter. And then the one in the middle on the top row is a plaque, or sorry, a patch, which is over 1 centimeter. Then the second from the left in the top row is a bulla, which is a vesicle or fluid-filled blister that's over 1 centimeter. And then there's a small sub-centimeter vesicle, the bottom third photo. And then there's a nodule, which is the fourth photo in the top row, which is difficult to appreciate from a photo, but would be a palpable lesion. And then it looks like a plaque, which is an elevated lesion over 1 centimeter. That's the last one in the top row. And then moving to the first one on the left on the bottom row, that looks like a papule. Next to that, it looks like some some dermal edema, which is consistent with a wheal, like hives. And then we already talked about the vesicle, and then it looks like a pustule next to that. So those are the primary skin lesions, and this slide might be a little bit more helpful because it clusters them together, but it's the flat ones, the maculum patch, and then a tumor would be a large subepidermal firm lesion. A papule would also be a palpable lesion, but it's sub 1 centimeter. A plaque is palpable over a centimeter. A nodule is a firm, it's like the smaller version of a tumor. Then we have vesicles and bulla, which are fluid filled, less than 1 centimeter, over a centimeter, and then pustules, which have like a pus-like or a neutrophilic debris. And there it is written out as well. For some reason, they've picked 1 centimeter as the distinction between these different nodules, or these different lesions, but that's how they're divided, basically small ones and large ones. And then once you've described primary lesions, you can further characterize them, which just helps you more in narrowing a differential. And for example, like papules, if they have a little central depression, you can classify them as umbilicated, and there's a list of differentials for umbilicated papules. Or if it comes up on kind of like a stalk, it would be a pedunculated lesion. If they look uneven on the surface, like warts, verruciform. So there are all these different words you can use to talk about lesions. And next, lesion distribution. So these are just some common examples of like how you would describe where something is. So on the extensor elbows, that's a papular vesicular eruption. It's an example of dermatitis herpetiformis. The intertriginous rash with the red patches and kind of these like satellite lesions of erythema, that's an example of candidal intertrigo. This truncal rash with hyperpigmentation is an example of pityriasis versicolor, also sometimes called tinea versicolor, that typically is hypopigmented in darker people and hyperpigmented in lighter skin. An example of a plantar rash, which this one is pustular psoriasis. And then a flexural dermatitis, which this one is atopic dermatitis, and you can see the associated skin thickening, which is usually because of inflammation and scratching. And then this was a diffuse rash. We're only looking at the trunk, but this is an example of secondary syphilis, which tends to be widespread. And then the arrangement, like I said, which is the relationship of the lesions to each other. Linear rashes, especially with these like small vesicles, very typical of poison ivy, and any kind of linear rash should make you think about contact derm because of the pattern of contact, essentially. You can have clustered rashes, like these are clustered in the finger bases, and they're dyshydrotic eczema. Can have confluence, like you see in this picture, which is an example of erythema multiforme. You have discrete lesions at the periphery, and then in the center, there's an area of confluence or an area where they coalesce. You can have secondary features to rashes as well. So they overlie the primary lesion and are part of the disease process, or they can be like an extrinsic thing caused by the patient. So you can have adherent scale over the primary lesion, like for a psoriatic plaque, the scale is just keratinocytes that have adhered to the top. You can have crusts if there's weeping or exudate from a lesion. That's like a crust is often used to describe the yellow, like the honey crust that you see with Staph aureus and impetigo. Excoriations caused by patients when they're scratching something really itchy. Erosions, ulcers, and fissures are all a break in the skin barrier, and then scars and keloids that can form as part of the lesion, or with aggressive scratching or trauma, like some like you can get some scarring rashes, like scarring alopecia, for example. Okay, so now that we've reviewed morphology, I was wondering if anyone would like to have a go at describing the rash of this patient. And I can go back to any slide that has like morphology distribution. And I can show you any photos of the rash, like if you want to see also, I have these ones in here again.
Who's brave enough? Matt, do you want to try?
Sure. Yeah, so no, I agree with Frida. I think it's obviously diffuse on many different body surfaces, but sparing the face. Just diffuse, you can see that some of the lesions are blending together. So I think confluent as well, then macular, because they're not raised. They're kind of flatter.
Yeah, agree.
Why
So,
not patchy?
Hmm?
Why not patchy instead of macular?
so, so I think because you see discrete macules and then you see that they have coalesced. And this is especially apparent, I would say, on the back where you still see a lot of discrete lesions. I think really what you're saying is that the primary lesion here, or how it initiates prior to its evolution, is that it starts as a macule. That's kind of a targetoid macule. And then it evolves into this more confluent patch of erythema. So I don't think you're wrong in calling it a patch either. But if you were to say like a confluent macular rash, it might clue you in more, describe more that it's starting as these macules that it eventually evolve to coalesce. And then I would also add, so the description that I used was widespread erythematous rash with macules and patches affecting the trunk and extremities, sparing her face, palms, and soles, with heterogeneous morphology, with some discrete targetoid macules on the back, a hemorrhagic area on the left arm, and then palpable purpura on her lower extremity. And notable that she has one visible blister on the abdomen. But that's obviously the non-concise description. Okay, so the as far as like once you see this huge blaring rash on this lady, as far as what approach you could take to classify the rash and build a differential just based on what you're looking at, you could take a number of different approaches. And if this is like just based on visual inspection and not necessarily the history she has, the like main features of this that make it unique are that it's completely widespread. She has a blister and she does have lesions that appear targetoid. So if you wanted to build your differential off one of those specific features, you can then further narrow it down by seeing like where there is overlap for where the three, where you see a diagnosis basically that appears in all three categories. And probably the more efficient way to do that would be to think about blistering rashes because the list is smaller, or targetoid lesions because widespread rashes have like so many different causes. And if we go through this list of common causes of each of these types of rashes, we can eliminate the vast majority from the differential. So if we look at widespread rashes and think about infections, you think about bacterial infections, like a big thing in the emergency department to think about would be like meningococcal bacteremia, which while there is like some non-blanching portion for her, that's not really, it doesn't really fit the demographic or the rest of the symptoms or what we're going for here. Other infections would be like erythema multiforme, which is typically caused by mycoplasma or HSV, but can be caused by drugs. So we keep that on the differential. Viral causes of infections, which far more commonly are in kids and cause like a widespread viral exanthem, so less likely for her. Acute HIV, also less likely for her. Ectoparasites like scabies or like reaction to bed bugs, but you'd see far more excoriations that would really be the cause of it being so widespread. Then inflammatory rashes like diffuse eczema can cause a widespread rash, or psoriasis, and going with, you can have widespread psoriasis, and in both of those cases you can get erythroderma, which is just like red skin everywhere. So based on the morphology, we don't really think it's that either. Drug rashes, huge on the differential. It goes with their history and then just the appearance of the rash. Like that's like a very drug reaction looking rash, which the drug rash itself could be EM, it could be on the spectrum, the Stevens-Johnson TEN spectrum, or it could even be something like DRESS. But we saw in her labs, there's really no eosinophilia. She doesn't, while the LFTs were hemolyzed, the kidney function looks okay, and it doesn't really fit the timeline for DRESS, which tends to happen 6 weeks after starting an offending medication. And we're more in the like 1 to 2 week time period. And then hives, which have a different morphology. Then for bolus disorders, you can have localized bolus or widespread. For a widespread bolus disorder, really you would zero in on like staph scalded skin, which tends to be a pediatric diagnosis. Immunobolus disorders, which has there are a few different ones that fall under that, like pemphigoid and pemphigus, which pemphigus vulgaris is the one that causes the flaccid blisters versus bullous pemphigoid. And then another one is linear IgA bolus disease and the immunobolus disorders, but we see SJS10 TEN on our differential there too. And then you can get a few different causes of targetoid lesions. The most like pertinent ones to think about in this case, or to quickly touch on anyway, like fixed drug, that tends to be one spot. And you do get a targetoid lesion, but it's much more purple looking than what she had. You could have a vasculitis that's a bolus vasculitis. But I think with her, this story of a common culprit medication, which is terbinafine and TEN, you would again think much more of like SJS TEN, which for her, do people know the difference between the two?
Body surface affected?
Correct. So it is body surface affected. So less than 10% is SJS, more than 30 is TEN, and then in between is this overlap syndrome. So really, I think for her, the big ones would be like EM, SJS, TEN, and then if she didn't have that blister, which really tips us toward TEN, it would be just like other drug rash. Just to quickly talk about the Nikolsky sign, which is useful for SJS and TEN. It was an exam finding described by a dermatologist in Warsaw a long time ago, Piotr Nikolsky. Like I said, it's when you apply tangential pressure to the lateral side of the lesion, and then it leads to an erosion or unroofing of the blister desquamation. It's representative of acantholysis, which means basically just the loss of coherence between epidermal cells. And then it suggests a blister that's occurring above the dermo-epidermal junction. And I've put here a couple of photos of what that looks like. So you get, you have adhesion proteins between keratinocytes, which are the cells above the basement membrane, and then you have adhesive cells between the basement membrane and then the dermal layer. So flaccid blistering disorders are above the basement membrane, and it's the membrane proteins affected that bind keratinocytes to each other, versus more tense blistering disorders, which are deeper and tend to affect the dermoepidermal junction. So the Nikolsky sign, while it is more specific and more suggestive of something like TEN or bullous pemphigoid when you do find it, the sensitivity is pretty low. So if you're not able to elicit a Nikolsky sign, that doesn't necessarily mean you're not looking at TEN, but hers was positive in this case. So positive Nikolsky for this lady, fever, this recent culprit medication, most concerning for TEN, and then we're also thinking about severe EM. Dermatology saw her very quickly. They did a frozen section biopsy, which showed interface dermatitis. And then they recommended transferring her to a burn center because of the severity of the skin lesions and the potential for deterioration. They recommended stopping all non-essential medications, stopping terbinafine permanently, listing it as an allergy. Because of the pathophysiology of TEN and its association with TNF, they recommended cyclosporin and then Enbrel, which is etanercept, the TNF receptor inhibitor. And then the closest burn center to us, I guess, is Cornell. So they recommended transfer there. Optho and GYN consults because of the potential for progression of her rash. And then skincare, which is emollients, and then special care to non-adhesive dressings because there's such a risk of desquamation and really like widespread skin loss. So just a few things about SJS and TEN. It's the pathophysiology. It's like an apoptotic mechanism. So it's thought to be mediated by the FAS and FAS ligand, which are proteins in the TNF family, and they're involved in triggering the apoptotic pathway for cells. It causes this diffuse blistering rash, widespread skin sloughing, and by and large, it's triggered by medications. The most common culprits of which are sulfonamides, aromatic anticonvulsants, allopurinol, NSAIDs, lamotrigine, and nevirapine. Usually this occurs within 1 to 2 weeks of initiating a medication. You can get a prodromal fever and some systemic symptoms. Stinging in the eyes is more likely to suggest conjunctival involvement. The rash is painful and rapidly progressive. We went over the distinction between SJS and TEN, and then it does tend to have a heterogeneous morphology. It can, even though we think of EM with target lesions at the beginning of TEN are targetoid, and they're distinguished by just looking a bit duskier in the middle. You can get blisters, you can get mucosal involvement, and erosions and sloughing. And the treatment is that you stop offending medication. IV steroids, there's really not a lot of data to support their use, but they still are used sometimes. There's no consensus on the dosing. And then there's better evidence to support the use of cyclosporin and TNF inhibitors. And then the rest of treatment is supportive skincare, preventing infections with like sterility around the patient. That's part of being on a burn unit. And then treating any infections as they come around, managing pain. You can use a risk stratification score called Score 10 that can help guide whether or not to monitor in a specialized unit, and then involve other consult services early, like Optho and GYN or GU, to if there's any involvement of mucosa. So this is what Score 10 is. It looks at age, prior malignancy, because malignancy is a risk factor for more, well, I guess these are all risk factors for more severe course of disease. And then the body surface area involved, tachycardia, and then these lab parameters. So based on the number of risk factors you have present, you can calculate a mortality rate. And this all comes from a study that was published in 2000. So take home points from this case, not to get overwhelmed by rashes and try to stick to a structure and have a system for building a differential. This should be with any rash, but especially one that's so widespread. Key to take a close inspection at everything and make sure patients are appropriately exposed. For an evolving widespread rash like this, examine eyes, mouth, genital region because it potentially affects your differential diagnosis and how you escalate care. Scrutinize the medication list. And then you can get dermatology to do an inpatient biopsy if they think they're looking at TEN. If anyone is curious, this patient was transferred to Cornell. In the end, we got the results of the deep biopsy, and it ended up being linear IgA bullous dermatitis presenting like TEN, but because that's such a kind of like out there diagnosis and it didn't particularly affect management, or at least triaging to specialist unit, I thought it would be much more high yield to talk about SJS and TEN. But linear IgA bullous dermatitis is a drug reaction that can present exactly like TEN. The distinction is essentially the pattern that you see on the biopsy. She got IV methylpred that was tapered and then changed to PO, and her rash resolved fairly rapidly. And she didn't have any scarring afterwards. And then we submitted this to a derm conference and to a journal as a case report because TEN, like IgA bullous dermatitis, is much more commonly associated with vancomycin, and there are no reports of this happening secondary to terbinafine. The thought was that she probably had some kind of like subclinical hypersensitivity to the terbinafine that was unveiled after she got the Moderna vaccine, and it just kind of kicked off her immune response.
And so what was the feeling how the blood clot was involved in all this? Totally separate?
So it's hard to say whether it was associated with Moderna for some reason. It was I'd like to know, because she was like under our care so briefly and then transferred to a hospital where I don't really have access to the records, so I couldn't see. But whether and because I didn't really like take a big history of when her swelling started. So I don't know if the swelling started before she got the Moderna vaccine and then she just happened to be on like higher alert about her body because she had recently been vaccinated. She presented shortly after. So I don't really know. I don't know if it was Moderna. Yeah. If she needs some malignancy workup.
Corinna, I have some technical questions. Just interesting. Was she on general medicine before the transfer? And
she wasn't admitted at all at our hospital. I was in the ED. I was working in the ED and SR in the ED.
Oh, okay, cool. That's actually good to know that it was stopped there.
Yeah.
The other question is, how fast did the frozen section biopsy resulted?
I think it was like 30 minutes.
Oh, okay.
It's really quickly. They do a bedside, and then he went off with the derm resident, went off with the pathologist, and within like a half hour, 45 minutes, he was back. And yeah.
Okay.
And the plan was to transfer.
Corinna, I have a question too. That was such a great case, an interesting case, and I think we're always scared of rashes. So thanks for going through all of that. How quickly can you see resolution or improvement in the rash typically with TEN? Because you said that she had really improved rapidly, but what's the typical time course when the rash starts to show some signs of improvement?
So it completely depends on how severe the rash is when you arrive.
Okay.
Because if she had just this one blister and the blistering didn't progress beyond that. I saw like one photo from Cornell where there was like a little bit of flaking on her back, but it looked more like, it didn't look as like red and beefy underneath. Like she had lost the epidermis, so it looked more like scaly healing skin, if that makes sense. So I don't think she had like widespread skin loss. For someone with really severe TEN, which I don't know if you've seen the photos with like bloody lips and like full body desquamation. I imagine the healing course, obviously the mortality is much higher with that as well, but the healing course I would imagine is longer, and then you can get scarring with that as well, which is a months-long process.
Thank you.
Is it quite common to have facial sparing and like, especially in like severe SJS/TEN?
I don't know the answer to that, but if you have like mucosal involvement, then it's not sparing the face. And it is like for TEN, it is common to get mucosal involvement. So as far as the skin on your face, I'm not sure, but certainly it's not uncommon to get conjunctival involvement and then involvement of the oral mucosa. And I think, again, it's more like a sign of how much it's progressed, because if you see really advanced TEN, it does affect their whole face. And she came at the singular blister stage. So who knows how much it would have advanced if she had come in a bit later.
I would say this is a great case to point out that even though we don't have derm here, you can get consults. Oftentimes they want to do a telephone consult first, where you're taking pictures of the rash and sending it over to them, and they'll just give you kind of a, phone kind of report, or they can put it in Epic as a telephone consult, but they will come over if they think it's severe enough. So this is a good case where they did do that. But I think too often we just don't think we don't have any derm services, and we do, and we can push for them if you're having trouble, having them to come over and take a look.
To me, it's interesting to look at this case, and of course, we always look. It's always easier to look, retrospectively. And when you describe the patient, and then we were in the ED, and you asked, "What would you do for this patient?" Matt said right away, steroids, IV steroids. And retrospectively, Matt, you were right. She ended up having high doses of IV steroids, and she responded well. Yet, to me, at that point of the discussion, when the patient was in the ED and we had to decide what to do, I'm not a dermatologist, I'm an internist, and, I'm very basic in my approach to derm. I ask, is it itchy, is it painful, is it just skin, does it involve mucosa, to get a sense of where we're standing. And in her case, to me, steroids at that point was, it didn't sound like a good idea in the sense that she was already on steroids and not responding. And then the second point was that even though the rash didn't look at all like a typical zoster rash, zoster 2 can give you atypical rashes, but she have, some blisters. And, steroids are contraindicated when you have zoster. So that would have been for me a reason not to jump to steroids right away. But, I think it is interesting that, this was something that, clearly required a biopsy because the differential was so broad. And the behavior, what to do was really very much dependent, I would think, on the diagnosis to know where to go.
And I would agree, because 60 milligrams of prednisone, which she had gotten, is actually a pretty high dose. It's obviously not as high as a IV dose, but it's a lot of steroid, and she didn't respond.
Actually, I have a question. Especially with like cancer, we always don't want to do steroids before a biopsy because you always say, oh, it's going to compromise it. Is it the same for this type of situation with skin rashes, or it doesn't really matter? Let's say that they ended up giving IV steroids. Is that going to compromise your biopsy, or it's okay to do that?
Well, I mean, in her case, she had gotten not a long course, but she had gotten 40 of methylpred and then increased to 60. And they still on the deep biopsy saw the linear IgA deposits. So it didn't, in that case, it didn't limit the yield of the biopsy. But yeah, I don't know. Steroids are used so much in dermatology, and biopsies still show you something. I think definitely with topical steroids, that can be an issue. Like it can kind of mask an underlying process, like an inflammatory process. Yeah, but I'm not sure. In summary.
I mean, I don't know either, but that was a great case. It was a lot of things that I think we don't really, I don't really know. So thank you so much.
You're welcome.
Okay, guys, let's take just a couple of minutes. We already have Dr. Ho here with us. I'm gonna share the QR code and we'll be back, let's say at 4:08 because it's a little late. Thank you, Dr. Prigolini. Thank you, Dr. Anjoli. Hey guys, we can come back from our short break. Hi, Dr. Ho. Thank you so much for joining us today. We have Dr. Ho from the Center of Stress, Resilience, and Personal Growth with us. I think they're coming back. Please, guys, turn back your camera. I know that's been like a long day. So we can start whenever you want. And I don't know if you want to create breakout rooms or if you want to stay in this main room. We will do whatever you prefer.
Thank you. I appreciate it. I think maybe what we can do today is, just to stick together and then we'll have a discussion. Thanks again for having me. I know you have a long day. I really appreciate you taking the time. What we're going to be talking about today, is about self-care. Would it be okay if I share my screen?
Absolutely.
Great. So as you can see, today we're going to be talking about self-care, and I can only imagine how you actually feel when self-care is often something that people talk about, right? And you're definitely encouraged to do, but at the same time, it really, really is a challenge. I would want to just, acknowledge that not only is this a challenge, for trainees, this is also a big challenge pretty much for everyone, across the healthcare system, particularly, for physicians as well as frontline workers. As you can see in here, everybody, almost 80%, right, of physicians recognize that practicing self-care is really important, right, to them personally, right? But only 57% of people practice it often, right? And maybe only 1/3 kind of do it sometimes. And I also want to recognize how difficult it is, especially, when you're in your residency years. We recognize that, with burned out, it's at least 50%, of residents do feel that way, and also have some symptoms of burnt out. So you do experience that, not only this is common, right? But also this is often, something that experienced by many people, and there are truly, systemic issues, involved in here. As you can see in here, a lot of the contributors when it comes to burnout, and including time pressure, how you just don't really have time for any other thing but work. Sometimes the work environment itself can feel chaotic, right? When there's just a lot of demands thrown at you. Sometimes you don't necessarily get to control, about what happens in a work day, under what conditions that you work. And, for some people, in some systems, there may be, a difference in the shared visions, between the providers and people who do the clinical care and people who are more on the administrative front. So when it comes to self-care, really, if there's anything you're taking out of, what we talk about today, is that it is not necessarily an individual issue. This really is, right, a systemic issue. As residents, you're already expected to balance learning, patient care, teaching, documentation, and still work at least 80 hours, for weeks and years to come. And, when we talk about self-care being really a bit of a mixed message, because, as, residents, when you doing all of that, the expectation to engage in wellness activities, including, and in addition to all the other responsibilities that you already have, can sometimes actually feel like a bit of an additional burden that you all have to carry. Like, especially with sometimes, right, the mixed message that, well, burnout actually may seem like a personal issue rather than a systemic issue, but truly, right, if this is a systemic issue, then the burden, right, shouldn't necessarily be just placed, on the individual, but the system itself, right, also has to take some responsibility. Now, today, I'm not really paid enough, right, to be talking about and addressing that on a systemic level. On the other hand, I'm also here, to address this issue with you individually, and also to see, if there are a little bit of something that each one of you can do to make this less so, of a distressing negative impact in the life that you already lead. So when it comes to barriers to self-care, I wonder if any of these seem familiar to you, or maybe something that you're experiencing right now? Anybody? Anybody feel like they have all the time in your world to do self-care? I don't hear from anyone, so I assume probably not.
I'm happy to volunteer. I would say the first two are the biggest barriers.
Can you say a bit more?
Oh, sure. So no time. I feel like no one in residency has time for anything. And it's hard. Honestly, sometimes self-care feels like work. So even if I do have time, I'm like, I'd rather sit on my couch, and maybe that's self-care in itself. But thinking like, oh, I should get a massage, or I should do this or that to feel a bit more pampered, sometimes feels like work in itself. So then I just neglect it. And then I have 2 kids. So I'm always putting other people's needs first. Yeah. And I'd say probably because of that, if I do spend time or money to take care of myself, I do not feel guilty.
Thank you, Corinna, for sharing. I think what you're pointing out, are again, right, some of that is systemic issues, but at the same time, you're also pointing out how when you are, putting, a lot, right, already in your schedule, sometimes self-care really becomes something on the back burner. Not only are you taking care of patients, you're also taking care of your family, and your other loved ones. And so, nobody, right, has all the money in the world to do all the self-care, right, that they need to do. And oftentimes in the prioritizing, it's, caregivers like you do in the healthcare system, you do put yourself very much maybe towards the end, in this priority list. What about the idea that needing self-care may be a sign of weakness, or it is something only vain people do? Has that been communicated to you? Is that something that, maybe an implicit attitude sometimes instead of something that's explicitly talked about? Like the idea of getting a massage is, oh, only those people do that. I'm not hearing that. So I guess that's not so much an issue. So people do recognize that taking care of oneself is not a sign of weakness. It does not mean that you're vain. Okay. Do you all believe that you're worthy of self-care? Yes, no, maybe. Well, if there are all these barriers, to self-care, well, it's so hard to do. Why bother? Right. Well, here we can see, poor self-care, right, is of course linked to high-level burnt out. But if you actually don't take care of yourself, it can, right, impact your performance at work, right? It can lead to errors, even though I know all of you trying really hard not to do any of that, right? And also, right, can be linked to, patient satisfaction outcomes. What we are saying is that, poor self-care can be, something that kind of seeps into, right, a sense of cynicism. Sometimes it may kind of lead to people conserving, their resources because they have so little left and they need so many people that they need to spread that to. Sometimes it may even, be linked to symptoms of depression and anxiety. Substance abuse, is a well-recognized problem, very under-talked about, right? Relationship problem, right? Attrition, right? And sometimes, in a very serious cases, though rare, it can lead to things like suicide. So what I'm saying is that why bother to do self-care? Because if you don't really neglect that, it can have serious outcomes, for both patient care and yourself. So when we talk about then self-care, I was like, well, you don't have all the resources in the world, right? You don't also have all the time that you need, right? So knowing what your stress level is and when you need self-care is actually critical. So this is where I would like to introduce you to a stress continuum model, because knowing that, right, will help you know when you need to engage in self-care. And this is a model that was originally developed by the US Armed Forces that divided spectrum of possible stress states into 4 color-coded zones. Are people familiar with this model? Have you seen it before? Okay, so I'm going to explain a little bit. So in the green zone, that's a zone, you know, when everybody's cool, everybody's chill. You may have some level of stress, right? But you're coping well and you don't really feel distressed at all by, right, the stress that you're going through. But in the yellow zone, that's the zone when people are experiencing mild as well as temporary distress, or even some changes in functioning. But the stress at the time is not exceeding your capacity to cope, meaning that in the yellow zone, the stress that people experience is more temporary, reversible, and would disappear completely once that source of stress is no longer present. Then it is the orange zone, and this is the zone I would like you all to kind of pay more attention to, because this is the zone, right, when people start to experience more persistent and severe distress or even impairment from stresses itself. This is the time when the stress is exceeding both in intensity and duration the functional limits, you know, of your own coping machinery. Whereas the yellow zone represents more like a bending under force, the orange zone can be a literal wound that is experienced by people. This is why the orange zone is a marker of risk that can be persistent, right? And can probably last after the distress or that stressor, you know, is over. The good news is that even though, right, the orange zone means that the distress is lasting longer than the stressor itself, most people are able to recover if they're able to intervene in time. Then, you know, after the yellow zone, it is the zone, right, of the critical distress part. That's the part when people are way past, you know, things, you know, being so reversible, so as to say. This is the time when this distress is staying longer, right, and is much, much more severe. You can think of it as the zone when people are starting to develop anxiety disorders, you know, depression, traumatic symptoms, substance abuse, you know, and etc. So let me ask all of you, given how important the orange zone is, do you recognize when was the last time you were in the orange zone? What were you noticing with yourself at the time? Now remember, the orange zone is you're transitioning, you know, from bending under force because of the stress to a point where things are starting to last longer, to a point where you need to do something about it because otherwise it could escalate and become worse. When was the last time you remembered that you were in the orange zone? And what were you noticing about signs for yourself that you knew this is now you're in this model considered injured, not just reacting?
I think probably you start being in a bad mood and you feel always overwhelmed, even though maybe you don't have that many things to do, but you feel like it's too many things to do. And maybe you try to do them and you do them all like badly and you don't even notice that you're doing them badly. I think sometimes you just notice backwards, oh, I made so many mistakes and I just didn't realize.
That's great. You know, what you're noticing is that perhaps it was not just a one day that you're feeling irritable. It may be, you know, for a few days, you know, you're feeling really crappy and you're maybe even snapping, you know, a little bit. I'm not saying this is what you said, but this may be one sign of it, right? You may feel like, you know, your work, you know, is often not satisfactory, you know, or to the point where, you know, you're just, you know, not happy or satisfied, right, with how much your effort has been, right, going into a certain outcome. That might also be a time when people noticed sleep issues. And we're talking about, you know, initiating sleep as well as maintaining sleep. And I often, you know, in my practice, tell people to notice when their sleep is being disrupted, because that's one of the earlier signs that things, you know, can really escalate and you don't want to wait until things, are in the red zone or when the anxiety is a lot more severe, for you to take into account these issues. What about emotional or thoughts that you might be noticing when you're in the orange zone? Is that a time when you're feeling particularly optimistic? Is that a time when maybe your attention or focus is more on certain issues, not so much others? Are there any changes in the way you're thinking about things when you're in the orange zone?
I would say maybe like you get thoughts of like, when will I not feel this terrible? Especially when you're that burnt out.
Yes, yes. Have people experienced things like, I'll always feel this way, nothing's gonna change, why bother? Why do I even keep trying? Sometimes people may be even thinking, well, this is what it is, it's kind of hopeless. Anyways, then you're becoming cynical about things. You may see that your effort don't really pay off.